Hello, everyone, and welcome to another EllieMD educational series. We're so excited to have you here as we continue our mission to support healthier, longer lives through education, innovation, and of course, community. Tonight, we're thrilled to welcome back Dr. Matt Segar. If you joined us before, you know Dr. Segar is a leading cardiologist and data scientist specializing in improving cardiovascular care. As a cardiac electrophysiologist fellow at Texas Heart Institute, he focuses on using machine learning and AI to develop cutting-edge risk prediction models, especially for diabetes-related heart complications. Dr. Sager's impressive background, including a residency at UT Southwestern Medical Center, a medical degree from Indiana University, and even a degree in computer science with a master's in bioinformatics. Wow, you're so impressive. He's passionate about personalized, data-driven healthcare solutions that truly make an impact. Dr. Sager, we're so lucky to have you back again. Welcome, welcome, welcome. How are you doing?
I'm doing well. I'm excited to be here. This is a topic that I'm really passionate about. So much is changing. Even talking to you guys a couple months ago, there's a lot of new ground to cover. So I'm excited to get going.
Oh, likewise. Well, to start, can you share a little about your journey into cardiology and what inspired you to focus on heart and heart health solutions? You touched on being an electrophysiologist or the electrician of the heart. Just tell us about your journey a little bit.
Yeah, I started in the technology space, was a programmer prior to medical school, got tired of looking at computers all days, so wanted to talk to people and really enjoyed medicine. And my journey has been very organic and serendipitous in a way. And I really enjoy the diabetes space. It's such a unique condition where there's a lot of really fun, exciting new treatments. And it's been a really exciting journey. And then the interaction between diabetes, the heart, entire body systems, cardiometabolic disease, as it's called, has really been a niche, fun area that I've explored and have been able to do a lot of trials initially with SGLT2 inhibitors, now kind of moving into the GLP space as well. So a lot of things that we can touch on.
I know. I mean, I'm so excited about our conversation tonight around all the studies that are coming out and what you've been part of. Can you just, for people new to this journey or GLP-1s, can you talk about how GLP-1 medications specifically benefit heart health beyond weight loss?
Yes. So let's first take a step back. And I think it's important before we start this conversation to talk a little bit about the history of these medicines, because by far and away, one of the biggest concerns that people bring to me are that these are new medicines. How do we know what is going to be happening? And so I want to, first of all, to say that these medicines have been around for decades. So the first GLP medicine came out in about 2004. So we've had over 20 years of established FDA approved GLP-1 medicines that we have seen very long-term side effects. So the first trial started in the 90s. So we have over 30 years of data for these medicines. So why are we talking about it now? Well, at first, these medicines were once daily, sometimes multiple times daily injections. Very unpopular in terms of prescribing unless you really, really needed it. But we did know that these medicines did help reduce weight loss or help improve weight loss for the last 30 years. It's really just when semaglutide came out that we went from daily injection with liraglutide to weekly injections with semaglutide that this explosion of new information's really come about. So these medicines have been around for a while. They're incredibly safe, but there's a lot of things that we should talk about. So specifically with the heart. So what we've observed is that GLP-1, so glucagon-like peptide 1, is expressed throughout the entire body. You have it on your vessels, you have it in your pancreas, you have it in your GI system, but you also express it on the heart as well in small quantities. And what you find is that when you act on that receptor in the heart, it has a lot of really favorable benefits. So by and large, what these medicines do is that it helps improve blood pressure, it helps improve heart failure, it helps improve cardiovascular disease, meaning dying from a cardiovascular cause. That includes stroke, MI, myocardial infarction, heart attacks, heart failure, and then also just reducing all-cause mortality. And what I mean by that is it helps you prevent death from any cause. It helps you live longer. And even the trials, when they're 3.5, 4 years, you're seeing upwards of 4.5, 5, 6 months longer longevity in just in that short time frame. So it's a really impressive medicine. And we can get into the nitty gritties about where exactly these medicines are working as well. But by and large, across the entire spectrum of cardiovascular disease, it helps reduce every single one.
Yeah, that's so incredible. And you were part of the dandelion study you mentioned, which was released in 2024. It was 7 times larger than Nova's trial.
Mm-hmm.
I think what it determined was that even those without severe disease had a 15 to 20% lower risk scores for major adverse cardiac events after taking a GLP-1 drug for 3 years. That's
Yeah.
so impressive. Can you talk about that and what else you determined from that study? Whatever you can share. Um,
Yeah, so these medicines first came out for the diabetes space. The way they initially were aimed, or the mechanism of action, is that it helps reduce glucose levels, sugar levels in the body, helps improve insulin sensitivity, makes insulin work a little bit stronger, so that these medicines were initially targeted for people with diabetes. What we've now seen with things like the SELECT trial, among others, is that they work in people without diabetes as well. So the effects in patients with diabetes are incredibly strong, reducing heart failure, reducing cardiovascular death. And just as well in people without diabetes, you see just as strong, if not even stronger, signals for reducing all the same outcomes.
now, what does the research say about GLP-1s reducing the risk of heart attacks and strokes specifically?
So the data is pretty impressive. You're looking at about a 20% reduction in what we call non-fatal cardiovascular disease. So not dying of cardiovascular disease, but the things that still affect you. You still want to prevent strokes. You still want to prevent heart attacks. You still want to prevent being hospitalized with heart failure. And for all three of those, it improves. So why is that? And I think it has to do a little bit with the mechanism of action of these medicines. So on your blood vessels themselves, you have some GLP receptors. When you act upon it, it releases nitric oxide. And so that helps vasodilate, expand those vessels, lowering blood pressure, lowering the stress on the heart. It also helps locally with inflammation in that blood vessel as well, help preventing, we think, plaque formation, which is the contributor to strokes and heart attacks.
Wow, I didn't even realize that. You're so with the nitric oxide, yes, and it dilates the blood vessels. It makes sense. Can you
It's
share a little bit more about nitric oxide for people who are new to the idea or concept? Like, what does it do in the body? What is it? What purpose does it serve? And the importance of it.
Yeah, so I think people have a really good fundamental understanding of this. They may just not realize it. So whenever when someone has a heart attack, for example, and they have those little nitro, give them like a little nitro paste or a little sublingual nitroglycerin, you put it under your tongue to dissolve. It's one of the first things we do in heart attacks. It's the reason why when you take nitric oxide, it vasodilates, it opens those blood vessels. Um, but it's a chemical little molecule that is very fast acting. It goes through the body incredibly quickly, and then it just latches on to different cells and then helps them kind of think of expand in a way, but relax is probably the better term. So you see it in a lot of the vessels around the heart as well as within the heart itself. But any sort of blood vessel kind of opens up uh, pretty quickly.
Yeah, but from what I understand, nitric oxide levels decline as we get older. I mean, it's a big buzzword in the longevity community, right? It declines. I mean, even mouthwash
Yes.
decreases the level of nitric oxide in our body. And so, right.
So there's different. So nitric oxide is expressed in lots of places in the body. So within the vessels, as a cardiologist, I deal with the vessels, but nitric oxide is also found in the gut, and the other place, GI system especially. It's definitely a hot area. I'm not a GI expert, but you're exactly right.
Right. Right. Well, this is really important to know. Thank you for pointing that out regarding the GLP-1s and how it behaves, how it relates to nitric oxide. So, can you talk to us about are GLP-1s a game changer for patients with high cholesterol and hypertension? Talk to us about that and why some
Yes.
people are coming off their statins even as a result of GLP-1s.
Absolutely. So I think the reason why again goes to the mechanism. It always comes back to why these medicines work, and then once you understand the mechanism, you can explain all the really amazing benefits for why taking these medicines is so awesome. So GLP is expressed also in the liver, which is the major organ responsible for lipid cholesterol metabolism. It essentially helps ramp up the good cholesterol in your body, HDL, while helping reduce LDL. Specifically, it works on different hormones like TNF alpha, TNF beta, cytokine release factor, all those kinds of things that are pro-inflammatory that are also have a important part in lipid metabolism. But throughout the entire spectrum of your lipid profile, you see really impressive benefits with these medicines. Some of it can be attributed to weight loss itself. When you have fewer fat molecules in the body, there's less likely that you're going to develop those bad cholesterol molecules. But the other part of that equation is it works in the liver directly to help improve your lipid profile as well. And so it's incredibly exciting when you may have, you're on the border, your triglycerides are high, your bad cholesterol, your LDL is high, you get on these medicines, and then your ASCVD risk. So in cardiology, we have these amazing risk scores that we use in our guidelines to help dictate or help prescribe statin medicine. So if your risk is above 7.5, statins recommended, but you're able to see with your lipid profile, your blood pressure, all these other things that get better, your ASCVD risk is lower and you may not need a statin anymore.
That is, thank you again. I mean, these are things that you pick up and you read, but you forget because we have so many patients that get on GLP-1 medications and their hypertension goes down. They're at 165 and it goes down to normal ranges in a very short period of time. So you're saying it's not just the weight loss, it's also how it acts on the liver. Wow. Guys, are you catching this? This is this is news to me. So thank you for sharing that. Can you talk about how GLP-1s improve insulin sensitivity and how they regulate blood sugar levels?
Yes. So this is the longest standing mechanism or understanding that we have of these medicines. So GLP was first identified in the pancreas. So the pancreas has these different cells, alpha cells, beta cells, that are responsible for insulin sensitivity. So when glucagon or GLP gets activated, it essentially releases insulin and makes it more sensitive to insulin. So if you have these medicines, it essentially makes insulin more sensitive and work more effectively so that you in response to food, more insulin's released, glucose levels come down, and all the benefits that you have are directly responsible because of the improved working of the pancreas.
Now, how does this affect type 1 diabetics? What?
That's an amazingly good question. These medicines have not been studied directly in type 1 diabetes. There's a lot of theories out there of that they work really, really well. I know of a few endocrinologists that are prescribing it with the understanding that you need to have very close monitoring. Have to have failed other therapies. The type 1 diabetes space is unfortunately not a lot of trials have. I literally had somebody a couple months ago ask, "Hey, you've developed a risk score for type 2 diabetes. Would you be willing to develop one for type 1 diabetes?" I looked into it. There's just not a lot of data in this space. So it's more, we don't know, not that it may not work. It's just that we don't know and don't have the population to test it in yet.
Now, a lot of physicians actually disqualify patients if they're type 1 diabetics getting on these medications. Maybe would you, as a cardiologist, would you disqualify a patient if they were type 1 or?
I would, just because it's going against the labeling directly. Now, there's other reasons why you may want to be on it, but it gets to be a hard conversation, and you need to have a really long conversation specifically with the patient themselves, and not just this carte blanche. Yeah, if you have type 1 diabetes, these medicines are okay. It's more of a personal patient physician relationship that you need to establish to determine if it's right for you.
Okay, so let's talk about long-term benefits for type 2 diabetes. What is
Yes.
there? What are the benefits?
Well, the biggest benefit is you live longer, period. There's very few medicines we have in life where you can say that these medicines improve all cause mortality, dying of any cause. That's such a profound statement when you think about it, that these medicines really do help you live longer. Uh, it not just helps you live longer, but it helps improve your quality of life. And that's so important as well. So we have a lot of these standardized questionnaires like the Kansas City questionnaire, KCCQ. You have your San Francisco questionnaire. There's a bunch of these standardized tests, which if you're in a clinical trial, it helps keep things protocolized. And across the spectrum, people just feel better across symptom relief, improving their activities of daily living, mobility, joint pain. It's a really impressive spectrum that these medicines work. I can't say enough good things from a symptom and quality standpoint.
Okay, so as you know, the recommendations a BMI of 27 and greater with a comorbidity 31 and
Mm-hmm.
above. So we offer the microdose version of it, and there's a lot of growing evidence around microdosing GLP-1s and all these benefits people are experiencing. Can you touch on microdosing and what you're seeing and what you're reading? And it's so incredible because 2, 3 years ago, when we, started in the compounding GLP-1 space, there weren't a lot of research and studies coming out around it. But now when you search research, it's like within a minute, I could come across 10 longevity studies around GLP-1. So what are you reading? What are you seeing? Can you talk to us about microdosing?
Yes. So the clinical trial data we have is on the very specified, start at zero point 0.5, trying to go up to 1, 1.4, 2.4, et cetera. But regardless of the amount that you're on, taking some is more beneficial than not taking any. So even anything that you can tolerate has benefits. Uh, the higher the dose, a lot of times you get a little bit better efficacy from a cardiovascular, major adverse cardiovascular event standpoint, but you still do see results even from very small doses. And the better part about that is that symptoms, a lot of the symptoms, side effects that you see are not as prevalent at much lower doses. Um, the studies that you're talking about are still coming out. I think there's some really exciting trials coming out in this space on much smaller doses. A lot of the data that we have right now is more in observational studies, but nonetheless, they've all been the same signal of these medicines work. Some is better than none. Whatever you can take is beneficial. Keep doing what you're doing, essentially.
I mean, we're seeing it with so many people where their brain fog goes away and they just feel better and they feel energized and on microdose levels, right?
Yes. So this was a really exciting, in the last literally 2 months that you and I talked last. The reason the brain fog, it's so funny you say that. It was a really small, like less than 50 patient, but it was a randomized study for dementia and um, other psychological uh, brain disorders. And what they observed, similar when we were talking about nitric oxide on helping vasodilate, the same thing was seen in the arteries of the brain, specifically in the hippocampus. So that brain fog that you exactly alluded to was one of the major symptoms that or side effects that went away in this study. So you hit the nail on the head right there. And we hypothesize it's because of the arteries opening up in the hippocampal region of the brain.
Okay, we'll talk about hormones in a little bit, but I want to touch on this, the brain and how it functions and mood disorders too. There's growing evidence that GLP-1s affect mood. How do they impact anxiety and depression from what you're studying and reading?
So depression is probably the biggest unknown right now. I've looked into this extensively, and I keep getting conflicting information. And I think some of it is because of confounding. And what I mean by that, so let's take a step back. So antidepressants, your SSRIs, your normal fluoxetine, like your normal medicines, they still have a black box warning that these increase rates of depression, even though you're taking it for depression. And that's because these medicines give you a little bit, make you feel a little bit better, and that you may have more energy to have suicidal ideation. Regardless, I think we're seeing the same thing in GLPs where people feel better. So they have a little bit more energy. So they're more likely to act on if they have an underlying depressive disorder that's not being treated appropriately, they may then have the energy levels to take drastic action. The corollary of that is that GLPs have been shown to reduce depression by a pretty good amount. I think there's so much we don't understand about the brain, and it works really, really well in some people. And then in some people, there's something that we're missing. There's something untreated that they're not being compensated for. That when we give these medicines, it's not the net medicine necessarily. It's something else being activated that's making them worse mentally. But I think by and large, the consensus is these medicines really do help with depression. And then absolutely they help with anxiety. I think that's there's not a lot of dispute in that area, that their activity levels go up, your concentration, and like we were talking about, the brain fog going away is such a positive benefit that's been very well studied now.
Yeah, and we're seeing it with our patient population too, where you're getting the spectrum. Some people are like, my depression has completely improved. I'm doing amazing. And some people are like, no, I'm feeling something. I'm feeling a little bit of funk. And I don't know if it's drug specific, where tirzepatide, for example, it's a GLP-1 GIP. It does work on dopamine. I do want to talk about addiction and how it affects the reward pathways, but could it be that the way that it works on the reward pathways, well, if it inhibits that in any sort of way, well, if you're more susceptible to dopamine receptor like depression, depressive episodes, right?
Yeah,
Would it affect you? Would it cause greater depression? I don't know. I mean, I'm reading conflicting information as well, and I'm
it
hearing.
is. It's a little conflicting. One of the newer studies, I think this came out in January, was looking at Parkinson's disease. So Parkinson's disease is typically a disorder of dopamine. You have lack of dopamine. The way we treat Parkinson's is giving essentially endogenous dopamine in different forms to help keep the levels higher in the brain. And when giving GLPs, they found that the one of the proteins, alpha synuclein specifically, was more reduced in patients that took semaglutide compared to those that did not. And they did that by imaging the brain with PET imaging. And this was, I think, a 6-month trial. There's something happening in the brain. There's so much we don't understand, but a lot of what we're seeing is positive. And if you have another avenue to treat things like Parkinson's, Alzheimer's, that'd be such an incredible medical achievement in a way.
Yeah. So let's talk about that. Let's talk about addiction, how they're using
Yes.
drugs to help with addiction and so forth. So maybe you could share a little about the studies that are coming out recently.
Yes, very recently came out after you and I talked last. So this JAMA Psychiatry, incredibly respectable journal. So this was 48 patients. So they call it a phase 2 trial, but it was still a randomized trial. They took patients that had alcohol use disorder, had problems with alcohol, randomized them to GLP versus placebo, and they saw again really profound decreases in alcohol use dependence in patients that took GLP-1s. And they actually were able to quantify it both from craving standpoint and the number of drinks that people drank per day. So by definition in the medical society, 2 drinks a day for a woman is considered alcohol use disorder. So if you're reducing that by over a drink, having 1 a day, that you're getting patients that had alcohol use to essentially more or less normal alcohol use levels. So really impressive results from a medicine over the course of, this was not very long, 4 months or something pretty short. Pretty nice,
What do
exciting
you,
information.
yeah, what do you hypothesize is happening in the brain? What is causing this?
Yeah, so that's such a great question. I think there's a lot of overlap with uh, food hunger, food craving, food noise, and the reward pathways in the brain. There's a lot of overlap with substance abuse, whether it's alcohol or other drugs, and food. Food can be considered a drug. It's something endogenous that you're have a craving for, and GLP is expressed very, very highly in the reward pathways of the brain. So you think of the front of the brain as more cognitive thinking, higher level thinking. Back in the brain is more your primitive, the things that you need to survive. Well, the GLPs work in the back part of your brain, things that essentially make humans human, the things that we need to survive, the basics of living, and the fact that it improves food craving and alcohol use, I think is kind of a no-brainer and makes a lot of sense.
Yeah, that to me is so interesting because I mean, there's studies coming out with smoking addiction as well. It's not just related to alcohol. We're hearing with shop
Yes,
addiction, smoking addiction. But what's interesting is it doesn't take away all the reward, right? Like people don't lose their desire to work out and exercise, or I don't know. It's just interesting how it's working.
it
Yeah.
is absolutely.
Yeah. So, can you talk to us about the GLP-1's effect on gut microbiome and gut microbiome health?
Yes. First off, this is such a difficult, unexplored area, just is a science in of itself. So the body of evidence we have in the gut microbiome, I think, is such a ripe opportunity for future research. Uh, we do know that a lot of what we can hypothesize is that there are a lot of changes in the gut microbiome. We just don't know how that relates to the mechanism or the benefits that we see. So we know that there are changes, but we don't know if those changes are what's contributing to the improvements in cardiovascular disease, for example, or if it's a byproduct of something else that's happening. So we talked about nitric oxide, that nitric oxide is expressed in blood vessels, heart, but it's also found in the gut. A lot of the nutrients that bacteria and microbiome use in the body in the GI system are affected when sugar levels are changed. So a lot of times some of the bad microbiome gut hormone or gut pathogens are reduced. They kind of die out while you have this flourishing of things that can be seen as more favorable. Uh, the the mechanisms and what that means, like I said, is still a little bit unexplored. Um, but I'm really excited and encouraged to see kind of what comes out in the future.
Yeah, well, I mean, it kind of makes sense when you have less sugar cravings, right? You're eating less, you don't have the same cravings that you did. You give your body that rest, the gut microbiome a rest, and also candida, right? Yeast and bacteria compete for resources. So you kind of your body goes into a state of homeostasis. I mean, it makes sense to me. Can you talk to us about these medications' impact on digestive disorders like IBS, GERD, or leaky gut?
Yes. So the biggest side effects that you see in these medicines are directly because of the mechanism of action. So GLP acts on the stomach to slow gastric emptying. So the food stays in your stomach longer. You can expect that you're going to have things like nausea, some indigestion, uh, and then you, some people get constipation, some people get diarrhea. It's impossible for me to predict. I tell people to be on the lookout for both, and if you have it, then we can treat it. So the nausea tends, a lot of these side effects tend to go away with time. They're horrible in the first, probably I usually say 3 weeks. A lot of immediately after taking the medicine, so they're once weekly medicines. The first 3 to 4 days after the injection can be bad. After your second injection, usually 2 to 3 days. After your third injection, a day or two, and then you're usually good after that third injection. The heartburn can be noticeable that first month or so, just because your body is getting used to more food in your stomach and trying to figure out how to empty the stomach. And like I said, the nausea tends to go away after that same time frame. Leaky gut, I think, is such an unexplored area and not my area of expertise. I'm probably as a cardiologist, I may be the wrong person to ask. Um, I I don't know much about that particularly. What I've seen looks favorable. I just personally can't explain the mechanism for why it's happening. I just know that it would be something. This medicine would be something I would consider if a patient came to me and said, "Hey, I have leaky gut," or "Hey, I think I have this." This would be a medicine that I would not hesitate to try.
Yeah, so going back to the cardiovascular benefits of these medications, now at a microdose level, and I'm saying less than 0.25 milligrams, for example, for semaglutide or 2.5 for tirzepatide, what would you still reap the cardiovascular health benefits at very low doses, even half of that, right? Would you still reap the benefits?
I yes, you'd still have benefits, absolutely. So if you're talking about what would I benefit from being on this medicines, yes. Is the benefit additive on higher doses? Probably, but it's hard to say entirely. Uh, a lot of times you need these receptors to be saturated in some effects so that the levels have to take time to build up. So I imagine from a microdosing standpoint, if you take it for a longer period of time, then the levels have time to build up in your body and exert their favorable effects. Now, a lot of the things that you'll have effect from may be take a little bit longer. So, for example, in these trials, you lose roughly 15% of your body weight in the first 6 months. It may take a little bit longer, but if you can still lose body weight and you have a better lipid profile and lab profile, all these other things, then yeah, a lot of the cardiovascular benefits are independent of just the medicine themselves, but all the other positives that your body's going through as well. So I'm 2.5 of tirzepatide is I'm that's a great dose. The less than 0.25 of semaglutide is a little bit less studied, but I would not hesitate to, if somebody's like, hey, that's what I want to try, please, by all means, let's do that. I'm excited for you.
Okay, on that topic, are you seeing differences in the two population groups that are using semaglutide versus tirzepatide? What are the studies saying about the two groups?
Yeah, so we have one head-to-head study from a weight loss standpoint on tirzepatide versus semaglutide. And tirzepatide, just because it has that extra hormone, it's GLP in addition to GIP, you see instead of a 10% or so weight loss with semaglutide, you see about 15% or more with tirzepatide. The cardiovascular benefits are very similar. From a weight loss standpoint, really is where you see the biggest benefit.
Okay. Now, if you were to give a patient a recommendation of which medication to go on, which one would you recommend to them? And
Yeah,
why would you put them on the other medication for perhaps?
I think it has to do with what their goals are. So if they came to me and is like, I want to I want to lose the most amount of weight that I can, I think it's a no-brainer. Tirzepatide very clearly shown to help reduce weight the most. If cost was the biggest issue, semaglutide tends to be a little bit cheaper than tirzepatide. If they're talking about the A1C benefits, I want to help control my sugars a little bit more, then tirzepatide lowers your A1C a little bit better than semaglutide. But if they're talking about, I just want cardiovascular risk benefits, well, semaglutide is the only one right now that's truly proven by the FDA to reduce cardiovascular benefits. And it tends to be a little bit easier to take. There's a little bit less side effects with semaglutide that I've seen than tirzepatide. So I think it's a great first medicine.
Okay, so talking about the future of these medications and their evolution. So now we have Retta that has come out. So what do you think about that? We have Retta coming out, and where is this going? What's the future looking like?
Oh my gosh, we could talk for an hour on these medicines.
Well, we want
So
to know that.
yeah, there's so much coming out. So the kidney disease data is amazing. There's a post-stroke study that's coming out. There's some Alzheimer's disease dementia studies. There's a lot more muscle preservation studies. I think it's the CagriSema, excuse me. So like semaglutide, tirzepatide, retatrutide, cagrilinotide. There's so many of these medicines. There's oral formulations that are coming out, long-acting oral formulations. There's twice yearly long-acting injectables, which would be incredible. And then there's medicines like the GLPs mixed with other things like amylin analogs. So amylin's been around for decades, but just like the liraglutide story, it's a 3 times daily injection for people that have pancreatic disorder that don't produce certain pancreas hormones. But we're getting into the once weekly amylin analogs as well. My research mentor at UT Southwestern just published literally last week a metabolic accelerator called HU6. It doesn't even have a full name yet. This was in JAMA Cardiology. Did incredibly well at weight loss, completely different mechanism, but didn't have the nausea, GI side effects, and it was really impressive. So, like I said, there's so much coming out in this space and so much exciting new information. I guarantee you, when we talk again in 2 months, this will be a completely different conversation.
No, absolutely. So obviously, with any sort of weight loss, muscle loss is almost unavoidable. So are there recommendations you would give patients who are on these medications altogether? Like, would you couple this medication with something else? Like sometimes we couple it with Somorelin to help preserve muscle and help with fat loss. But what would you recommend if you're getting on these medications for the first time?
Yeah, so we studied the liraglutide. We got MRIs of the thigh and belly, so we looked at central adiposity, the fat around the belly, as well as fat within the thigh muscle itself. We did this over the course of 6 months in longitudinal MRI studies, and we published this in the Journal of Sarcopenia and showed that the amount of fat that you lose in the muscle itself is pretty profound, but some people, about half, also lost some muscle mass. So we went back and looked at this, and a lot of it was because they weren't getting the daily nutrients that they would normally get when they were eating more. So when you feel nauseated, you just stop eating. It doesn't matter the mechanism of losing weight. In anything, if you stop eating, you're going to lose muscle mass. So the biggest thing that I say is still try to get your daily nutrients of your protein, carbohydrates, fats, healthy fats, and then water intake, especially because kidney stones is another thing that we're starting to see because people just stop drinking water, and it's not a really good sign. The Sormelin is a really hot, interesting idea. If somebody came to me and asked if they should be on it, then I would not discourage it. I just don't know enough from a research standpoint to fully recommend it without them doing their own research as well. But mechanistically, it makes sense to me. I just don't think that there's been enough studies in that space directly. But weight training, getting your normal aerobic exercise, anaerobic exercise with lifting weights, making sure you're still trying to maintain the mass that you have is by far the best treatment when you're getting on these medicines.
Oh, that's wonderful. And guys, if you have questions for Dr. Segar, especially, I mean, he's a remarkable cardiologist. So if you have any questions, please post it in the chat section and we'll get to it. But Dr. Segar, what else would you say around these medications and longevity? I mean, what's the consensus? You recommend this, obviously, but is there
Yeah,
anything you'd like to add and tell us
yeah.
if
Let's talk. Let's talk about something we haven't talked about at all, and that's PCOS. So I am very hopeful in the short future that the FDA will recommend this for PCOS directly. And this is because of a couple really profound studies that have come out on looking at actual ovarian follicle changes on these medicines. So you get differences in androgen sensitivities with these medicines that help improve PCOS symptoms and the disease that is PCOS. And that's not to even take into consideration the weight loss effects, the improvements in estrogen handling and other hormones that are independent of these medicines as well. So I'm very hopeful in the short future that PCOS will be one of the approved treatment reasons for these medicines.
Yeah, that's interesting you say that. I just recently, last week, met someone. She was very healthy, an athlete. But she wasn't when you think of PCOS, like that was not, she's not someone that you would think of. And her doctors at 18 put her on these medications and it has completely changed her life. So she was so excited to share this with as many people. And so we also have the sleep apnea. It's been approved for sleep apnea.
Yes.
Foresee anything else that these medications will get approved for? Do you think one day it'll be a
Yeah.
front for Alzheimer's and dementia? What else do you see in the
I,
near?
yeah, absolutely. Alzheimer's, dementia, osteoporosis is another big one. And again, goes to the mechanism. So I always remember from medical school, osteoblasts build bone. I still remember that from my histology slides. And GLP is expressed on osteoblasts. It's very cool. So these medicines help build bone and help keep the strength of the bone in check. And it helps prevent osteoclasts, which help break down bone, from functioning. So it has both effects. It helps build bone and it helps prevent the bone degradation from happening. So another really exciting mechanism, I think, in the future. Pediatric diseases, there's other types of heart failure in the cardiology space. So there's two types of heart failure. There's heart failure where your heart doesn't squeeze as well. We call that HFrEF, or heart failure with reduced ejection fraction. There's also HFpEF, heart failure with preserved ejection fraction. That's where your heart gets a little bit stiff, doesn't relax, it doesn't open up as easily. This medicine will absolutely work in this population. We're already seeing it before the trials have come out, and that's because these medicines work by helping muscles repair themselves, reducing fat. When you reduce the fat, the muscle can stretch a little bit more, relax. That nitric oxide, like we talked about, the heart failure symptoms kind of go away. So yes, so many things we can talk about that are still continuing to be explored.
I'm getting some questions coming in, so I'll
Yes.
throw some out. What can I pair my tirzepatide with to help with my CAD?
The CAD meaning coronary artery disease. Is that what we're saying?
Mhm.
So that's a good question. It depends the level of coronary artery disease that you have. So if you're somebody that has a stent already, then you need something to help thin the blood. These medicines don't really help with blood thinning. So you'd still need your aspirin. If you've had a stent in the last 12 months, then you need 2 antiplatelet agents. As of now, the guidelines still recommend a statin, not because they want to reduce your cholesterol levels may be really low, but there's something about having a stent in your heart where the cholesterol gets a little bit sticky, and that you still develop these plaques, and statins still do help prevent those plaque formations in stented areas. But if you're somebody that just has, we call non-obstructive coronary artery disease, then there's not much you really need to be on besides making sure your cholesterol levels are in check, less than 70. And then an aspirin's a very hit or miss question on whether it's recommended. There's a lot of data that you don't even need an aspirin anymore. So it's a good question for your cardiologist as well.
Mm. Angel asked, what would you recommend for COPD and emphysema?
So there's obstructive sleep apnea is one of the, as you alluded to, one of the indications to be on GLP-1 medicines. And a lot of times it helps decrease that neck circumference so that your glottis doesn't drop and obstruct your airway during sleep. So by and of itself, GLP-1s are an appropriate treatment. Now, if you're not responsive or you're having other obstructive disorders, then a CPAP and seeing a sleep specialist is paramount. There's a lot of really cool things now in sleep apnea where they can have essentially use electricity to help keep your glottis open and when you sleep, so that you don't need to even wear a CPAP. And those are put in by usually ear, nose, and throat doctors. But from a GLP-1 medicine, it's an indicated reason to be on it.
I love this question. We get asked this all the time, and I would like to hear your opinion on it. Is it true that you have to be on GLP-1s forever?
That's a great question. So the data that we have now is you tend to a lot of the weight that you lost tends to recur. That's a lot of times because you go back to your old bad habits. If you go back to eating a lot of the same things that you did before you're on these medicines, yes, a lot of times you'll regain the weight. Some of the effects are long lasting. Like if you learn portion control, if you help, you can very well more or less cure your diabetes by being on these medicines. And then if you maintain a lot of those same habits, then a lot of times we don't see weight gain come back. Some of the newer medicines that you were alluding to, or we were alluding to, you don't have that weight gain. So I tell people, if you can be on these medicines, I am very confident in the next couple of years, we're going to have something that's even better and greater. And one of these medicines is actually a long version that after you come off it, you're not seeing that weight gain come back. So it's still a really exciting area.
Yeah, someone asked recommendations for perimenopause and GLP-1s. Can we talk about hormones for a second and these medications, how they act on our hormones and how they help? Uh,
Yeah. So we alluded to it a little bit earlier with PCOS. So these medicines act directly on your ovarian follicles, as well as fat cells, adipocytes that help regulate hormone levels. They improve estrogen levels. They improve testosterone levels. Um, Across the gamut, they're helpful. Specifically in perimenopause, when you have a lot of fluctuations in hormone levels that it can occur hourly, it seems like minute to minute, and you have, go from hot to cold and hot flashes, and you can be pretty miserable. A lot of the current therapies that we put people on are the same types of pathways that GLP-1 medicines work on. So when you're talking about uh, keeping kind of that homeostasis and things in check so you're not having those wild fluctuations, we are seeing some kind of observational data that this is helping, especially hot flashes in particular, uh, in that perimenopause period.
hmm. I have someone that just asked, any evidence of these medications working to reduce calcium artery scores?
That's a great question. So, uh, yes, but calcium artery scores in and of itself can be a little bit biased because if you're already having calcium in the artery, then it's already formed over. It's already a hard plaque. It's really not going to go away. Where it really helps, though, is in the stuff that's not fully calcified yet, because then it has time to regress. Once it's calcified, it's essentially, think of it as a stone. It's not really going to go away when it's completely formed. What we care about is the stuff that can continue to grow. And so if you can get on those early and help regress some of that plaque formation, then that's really the higher risk stuff that we're targeting. And yes, by all means, GLP-1s can help those kinds of plaques.
Mm. Susan said, I asked this earlier, but as an electrophysiologist, do you think there may be benefits for AFib from GLP-1s?
Yes, and the study is coming out next month. I'm so excited. So atrial fibrillation and GLP-1s are coming out, and I'm so excited. I saw the results early, and they're profound. So yes, absolutely, and it's for a lot of reasons. We talked about it's because in the heart, but the reason for atrial fibrillation is because you have little bits of scar in your atrium, and that signal kind of goes all haphazard and goes all crazy, and that's what can cause atrial fibrillation. So if we help decrease that fat, decrease that inflammation in the heart, then atrial fibrillation doesn't have as much of a pathway, as much effect in exerting itself. The normal signal kind of goes through unchanged so that atrial fibrillation doesn't happen.
Can we just ask, do GLPs or GIPs have benefits for someone with epilepsy, or should it be avoided?
That's a great question. I man, I do not know that answer. I've been doing this for years, and that's the first time I've been asked that. I'm not going to comment without knowing for sure. That's an amazingly good question.
Mhm. Which peptide for AFib? Someone just brought that in.
So that's a great question. The GLP and GIP have shown or will show to reduce AFib. The one corollary to that is the triple agonist, Reta, has glucagon agonist as well. Glucagon is expressed very highly in the heart, specifically in the right atrium. I wrote a paper on this. I love this topic. And what else lives in your right atrium? The sinus node, which is the main pacemaker cell of the heart. So when you give glucagon agonist, your heart rate goes up. So there's a little bit of an arrhythmia risk that you see with that triple agonist that you're not seeing in the other medicines.
That's really interesting because a lot of people are saying that that's a side effect of Retta, right? The arrhythmia. Angel just came back and said, my question is about COPD, not sleep apnea. I'm referring to the respiratory system and lungs specifically, the benefit of GLP-1s on COPD.
Yeah, that's a good question. Unfortunately, COPD has been a major exclusion for a lot of these trials. And the reason for that, there really isn't a great explanation for why. You can hypothesize that COPD is a problem with lung expansion, and your lungs are kind of chronically enlarged. And if you can decrease that abdominal pressure through weight loss or other mechanisms, that the lungs may have improved compliance is the word. The other thing that it may improve is the inflammation in the lung and the scarring in the lung. You're seeing this in other body systems, so it makes sense mechanistically why it may help in the lung. But unfortunately, a true study of COPD and GLP-1s hasn't been done, but it seems mechanistically like it would work.
Okay, sorry, there's a lot of questions coming in. I'm
That's
trying
good.
to filter them, but could someone diagnosed with Graves' disease continue to use tirzepatide to potentially regulate heart palpitations and heart rate?
So not for this medicine. So because these medicines in some ways increase heart rate, especially with the triple agonist, but for on population levels 1 or 2 beats, even with GLP-1s, it's not great at regulating heart rate. There's a lot better medicines at regulating heart rate. You always worry. So one of the major risks with these medicines is patients that have thyroid or medullary thyroid cancer. That is a absolute contraindication. Graves' disease isn't a cancer by any means, but there are some concerns when you have thyroid disease and taking these medicines in general.
Okay, what if you have thrombophilia? Can you take GLPs, or is there a certain peptide that would be safe for thrombophilia?
That's a good question. So there isn't a specific contraindication for having low platelets to not be on GLP-1 medicine. Sometimes the reasons why you have thrombophilia may be an exclusion criteria. There are certain cancers that can cause it, but in the absence of anything that's the direct cause of your thrombophilia, then there's no real contraindication from a GLP standpoint.
All right. Okay. I think we're gonna, Hashimoto's, that's another one where we have so many people who are
Yeah.
Yeah. Can we touch on that real quick? And
Yes.
arthritis, any sort of immune disorder, can you touch on that?
Yeah. So the arthritis is a interesting one. There's lots of different reasons why you have arthritis: psoriatic arthritis, rheumatoid arthritis, or just osteoporotic arthritis. A lot of the autoimmune stuff is underexplored. A lot of the observational stuff, for one that just came out literally in January of this past year, showed that there's marked improvements in rheumatoid arthritis with GLP-1 medicines. Thyroid disease, again, similar, like other end of the spectrum from Graves' disease, but with Hashimoto's, you'll always have people that get a little bit nervous when they see thyroid disease and GLP-1 medicines. It takes somebody that really understands you and your personal story and your personal risk factors to kind of discuss the risks and benefits. So it's never something that I just unilaterally say, but it's definitely a conversation to have with your individual physician.
So Dr. Segar, with just a few minutes left before we wrap up, we have a huge population, more and more people. I mean, 3 years ago when we came out with the compounded semaglutide, like it was new still. A lot of people didn't know about it, but it's becoming very common now. A lot of people are hearing about it. They're trying it. They're reaping the results. All right, so we have this population that's taking it. We have a 70% overweight population, right? Let's assume that the 70% sees the improvements. What next? What will happen next? Where do you see the future after semaglutide?
That's a great question. I think that if we can, as a society, control a lot of these things that are causing a lot of comorbidities in the population, like being able to have improved mobility, just the general day-to-day living that a lot of people may have some difficulties with getting around, symptoms. It's a really exciting time that a lot of these things can be curbed or definitely improved upon. A society where you can get out and move and have much more mobility is definitely a happier society in my mind. Keeping people out of the hospital is such a benefit. You go from treating, you go to helping prevent disease instead of just treating disease. And that's a much more enjoyable conversation to have, just society-wise. Uh, Long term, I think there's a lot of unexplored stuff that we could be doing. A lot of the work that I'm doing is trying to identify who benefits most from these medicines. And hopefully the next time we talk, I'll have a lot more on that topic as well. Uh, but yeah, I think that there's a lot that's changing. There's so much that's coming out. I hope we have these regularly so that we can continue to keep up to date with everything that's coming out in the studies.
I know, and so much is changing. And you mentioned that for the first time in a long time, the obesity rate is going down slowly, which is
It is
so
unheard of.
encouraging. It's like the healthcare cost of the nation and the overall health. If we can get a healthy society, imagine how much more productive we can be and those quality years. My God. So it's an exciting time, and I'm looking forward to where things are going to go in the near future. But thank you so much. As always, we love, love, love having you here. Please come back. Please educate us.
Absolutely.
Bring the information that you're gathering to us. Thank you so much. And thank you all for joining us this evening. Thank you, Dr. Segar. You're
Of
wonderful.
course. It's always a good time. And thank you for all the work you've done. It's absolutely impressive. And you're doing it the right way, as I always say. So keep up that as well.
Oh, thank you so much. Well, that wraps our Thursday educational series, everyone. We'll see you very, very soon. Thank you again. Have a great night. Good night.